Welcome to our podcast today. I'm your host, Travis Garland, the CEO of KickstandAI, where we solve practical problems that amplify the impact of healthcare and wellness organizations through automations and AI technologies. Today, we're joined by Amy O'Malley. She's the Director of Operations and Programming at Good Beginnings Therapy, a pediatric therapy practice serving families in Northern Virginia since 1989. Good Beginnings specializes in physical and occupational therapy for children, offering programs like toe walking clinics, feeding support, and pediatric incontinence therapy. Amy brings over 2 decades of experience in pediatric physical therapy. She's a board-certified pediatric clinical specialist and has led outreach projects beyond U.S. borders, including Haiti and Russia. And in our session today, we're going to dive into her journey. We're going to talk about the evolving landscape of pediatric care, and we'll uncover hidden budget drains that hospital and practice leaders often miss. So with all that, Amy, welcome to the podcast.
Thank you, Travis. I'm really excited to be here.
Yeah, happy to have you. So tell me, pediatric physical therapy, what got you interested in that?
Oh my gosh, the real story that I can keep short is I always knew I wanted to be in healthcare. I was 3 years old. The family story is I either want to be a doctor, a nurse, or a Burger King waitress, because that was the time they had those cool crowns. And we weaved that out. And so I always knew healthcare. Even as a child, I always wanted to go to the doctor, freaked my family out. And as I got older, I'm born in the early 70s. That was all we knew was doctor or nurse. And I realized as I started investigating in high school, something was missing. And then there was this movie, I'm not going to lie, it's called Red Heat with Arnold Schwarzenegger. Okay. And there was a character who was shot, a cop in Chicago who was shot. Huh? And the movie's fun. But at the very end, he was in the hospital in what PTs call parallel bars. And that's what you use when somebody can't stand up and walk and you're in the hospital. And there was a character in scrubs, medical scrubs, holding him up. And this person started taking their first steps again by holding these parallel bars. And my parents to this day say, I leapt off the couch and I yelled, "That's it. Whatever that is, I want to do with it." And they said, great, we'll start investigating. It's like the early 90s. So that takes time. And a few weeks later, my mom had to go to outpatient physical therapy. And she brought me with. She said, hey, can my daughter come? She's interested. And they said, great. And then I started volunteering there. And then every job, literally since I was 15 years old, is tied to physical therapy.
Wow. So lightning struck one time and you were on the physical therapy path since then.
Mm-hmm. And then all the way through graduate school, in college and graduate school, I'm like spinal cord injury, pediatrics. And I love kids too much. So it ends up being the right sweet spot for me because I do what's called developmental pediatrics, which is not just kids at the hospital, but the process of development. So from birth to whatever age, now it's young adults with disabilities or impairments, I am treating the system that should have made it okay. So whether that's a birth injury, a big birth injury or a small birth injury or a pulled neck muscle or something bigger than that, I'm looking at the developmental process that goes with it, not I was a healthy child and broke my leg and had surgery. There's a couple of different venues inside of it. And that kind of guides everything we're going to talk about today. So
yeah, it sounds like it. And speaking of your evolution as a physical therapist and into pediatrics and where you are right now, certainly your role within Good Beginnings has changed. I think you've been there for quite some time, 10, 12 years, something like that.
21 years, actually.
Oh, goodness
21 years this September.
All right, fantastic. So,
out of my 26-year career.
For a long time then. So certainly bring me through the quick version of maybe not necessarily your specific role within Good Beginnings, but frankly, I know that folks like Sarah Weiser has been part of creating this momentum for Good Beginnings. How do you play in that? And where have you seen Good Beginnings given your 2 decades of experience with the organization? Where have you seen it really evolve from?
So I saw it evolve from a single owner prior to Sarah and very part-time employment. So a prior owner who had some friends who were helping her out on their off time with some PT and OT needs, to her hiring me as her first full-time physical therapist, to Sarah being a part of that small team at the time, to an opportunity to buy into the practice when it was still very small, one location in a basement suite in the building we're actually still in. And Sarah was able to buy in. The rest of us weren't really able to buy in. She had an opportunity. And Sarah co-owned it with our original founder. And then our original founder retired. And then Sarah took over. And along the way, what we found is people you can't run a smaller business without a team, without a real team. And the bigger your needs get, the more of a team you need. And what Sarah has been a genius at, she is a really good entrepreneur, is recognizing that and having a small business background with her family and saying, well, if we need this, then we're going to do this, and this is how we'll make it happen. And we just started expanding along the way. I think it's just generationally part of who I am. I'm also just someone who jumps in to help. So as there were challenges, I just offered, do you need help? Do you need this? And as I got to know things, she would, always next, there would always be like a little bonus or something to say thank you. It just wasn't necessarily my job yet. And then when I got really big, we had gotten enough where we were going to hire salaried employees and do things. She took me aside and said, we need a structure. Like, I'm going to get a business coach and we're going to have a structure. And my goal is to see if that interests you. Do you want to just be a clinician, or do you want to do these other things? Because you're very well versed in many things. And how can we make that work? And we've spent the last, at least a decade, it's been more than a decade, evolving that structure. And so she's kind of our, CEO alpha, and we call me her beta, like in a wolf pack. So I do a little bit of everything. I'm still treating, I'm still teaching. I teach within our clinic, I teach without our clinic. I know about all the operations and management. We have people under me for that now to help with the day-to-day. We have much bigger admin teams, and my biggest focus is creating all the programming, like the things that we need clinically, but also being an outreach speaker and teaching, and then making sure that our doctors feel good about what we do and knowing how that all goes. It's kind of a lot of little things.
Yeah, it sounds like it. It sounds like you're sort of the COO and the right hand of the alpha, as you put it. Let me ask you a little bit about some of your outside of the U.S. experience here, because it feels like you have been in this space for quite some time, but naturally informed by other experiences in other healthcare systems and how that might differ. Tell me a little bit about how it is that you sort of picked up things from those lessons and brought them here to the U.S. Help our audience here understand what lessons you're picking up or how things are different.
So and I've had the opportunity to do it under different guises. So it's all volunteer at this point. You're donating your time and through different organizations. And one time when I was in Haiti, I was teaching the students and working in the hospitals. And then when I went to Russia, I was teaching the doctors. It was more of a professional level interaction. That was a great program where they had like 4 neurologists at the time in all of Russia who could diagnose autism and certain special needs. And he had a partner who did cognitive development. And so they invited me over, and we would go around and tour areas of the country and teach therapists and doctors and start to have collaborations. So I got to see it as a provider. And then I was adjunct faculty at one of our local universities, and I went to some other countries to help them teach their graduate students. They would do these abroad programs for 2 or 3 weeks to get their students to see other healthcare systems. That was in Costa Rica and Nicaragua. And then through another small foundation, usually as one fades out, like they lose funding or there's geopolitical issues, another fades in. We went to Eswatini in Southern Africa, and we worked directly in the community at special needs schools. They don't really exist. And so we were on the ground teaching people there and coordinating with systems. So it's quite a variety of systems that selfishly I just did to see the world and help out. That was going to be my way. I wasn't going to backpack through Europe with my student loan debt. So I went and volunteered all around.
College trip, right?
Yes, I didn't get to have that. I started grad school 3 weeks after graduation. So, what I found is it's so diverse, and that was part of it. Like, there is such diversity, and our system is pretty specific. It's comparable to, we studied this a little bit in undergraduate, it's comparable to the UK, it's comparable to the Canadian system, except it's not nationalized healthcare. But it's kind of the closest what you see out of the countries I've been to. But every country I've been to also has a private aspect. Like, nobody's getting it done with just national health care, and even if they want to. And so that is a nice eye-opener to see that every culture has some aspect of private pay built in and is more accepted in other areas to get what we need. We understand it's a subsidy, but not an entire the word is, it's scary, but it doesn't entirely erase my burden of cost. And so that's been one thing. The other thing is just so many there's business cultural factors, there's political cultural factors, and then there's just like developmental cultural factors. So like, for instance, in Russia, there were people from the Ministry of Health and probably people in the Secret Service who monitored what I was teaching to make sure that I wasn't causing political unrest. And further could I have been from the truth? It was pure interaction on a clinical level, right? But there, I had meetings with people. I was interviewed by Russian news agencies because there were definitely concerns of that area which inhibited what we were able to do. In other countries, there might be corruption that we're working through. In other countries, there might be safety issues that we were working through, like Haiti. God bless Haiti. is an environmentally unstable country, right? Between earthquakes and hurricanes, and then there's, geopolitical stability. And some of my stories were trying to go into the hospital, and there's armed guards at every door letting me know how armed they are to ask what my business is there. And, those are not the things we have to worry about in America. What we have to worry about in America is a lot more the consumer. The consumer has a lot more agency, and who really has the most agency is the payer agents, because our original system was developed as somebody provides this for you. Right? Like, that's how I learned even from my older generations. You got a job, you stayed at a job, you got these healthcare benefits, and there's very little cost involved in that. And then you get a pension, and there's something related to that. And healthcare as a concept was never considered something you had to be responsible for. And as the world progresses and financial patterns change, that's changing. And this is the country I find that's the hardest to understand in.
Yeah, I can only imagine. There's cultural elements in every country you go to that have to be tied into that. I think that makes perfect sense. The political space, shocking, not a unique thing here in the U.S. We're experiencing that right now, and certainly as current things are closing and reopening, we know that's changing how funding is impacting certain populations within our healthcare system. And when I think of how it is that you've gone overseas and you've been able to help really frontline folks all the way up to, very educated physicians who are doing specific things, and they're really kind of needing that expertise. The idea of a small to a large organization creates that dichotomy that we've talked about here, kind of leading into our time together, which is there's some sizable chasms opening up between really small practices and those larger organizations or payers. Since you also mentioned that idea of sort of the payer institution kind of driving a lot of the policy, if you will. When you think of those differences, how do you see technology or the systems really landing between an organization that might have a relatively small footprint compared to a large health system like, say, a Mayo or a Kaiser, or these large kind of health systems that can throw tens of millions of dollars at technology? How do you see that experience different from your view?
Please correct me if I go off on the wrong tangent that's not answering your question, but I think the potential for technology is a great equalizer if used correctly, right? If used ethically and resourcefully, and if it is appropriately priced for what people need. And I think what's hard about all of this related to insurance or healthcare access and things like that is everything costs money, and it's very hard to pay for things to fix a problem, like in general. Right? Like if our cars never broke down, we'd never need new cars, but then people wouldn't need to fix them. And that would be great. But if they do break down, there's a cost associated with it. And all you get back is something back to what it was. And that's a really hard concept, right? And insurance in general is a hard concept because, you're paying, and the system really works is we're paying into a system so that only some people need to use it. And we're hoping that the way it all levels out is people use it in sparingly or in different areas so that it all balances out. And some people won't use it a lot, and some people will use a lot, and that's hard because at some point somebody has to pay for everything. And how do we make that accountable yet accessible and fair and ethical? And so technology can be an equalizer in so many ways. One of the things we learned during COVID or post-COVID was the advent of Zoom to use the product, but telemedicine, right? And we went into it going, there's no way we are going to enjoy this. And thankfully, Sarah, being the entrepreneur she is, had been prepping for a couple of months. She had felt the wind. She really believed it. I was on the fence, but she did all the prep. And the day that we closed, March 17th was our last day in office. March 18th, we did 80% of our scheduled visits online. And within 1 week, we were up to 100%. We were ready to go. And our outcomes are amazing.
That's a number that is astronomical to me. Not the fact that you hit 70 or 80%, but that you did it within a week. That's something that not only is that a lot of foresight, but it's also the ability to connect with your patients and your families in a way that helps them to understand what this new technology or this modality might do for them. And it's something that I'm a little bit surprised about how quickly you got that adoption taken care of. How did you manage that? Was it through just Zoom or was it a video thing? Like what was it?
It was through Zoom at the time. We used Zoom, but Zoom did a great service to people. They gave us free HIPAA enforced accounts during the pandemic. Okay, so technology made itself ethically available to help us weather the storm. And we had prepared for Zoom, and we probably started in December, really having a prep for it. And we had some people prep on the clinical side and some people prep on the technology side, because what I guess I might not have said is we are now a much larger institution. We have 2 offices. We could have more, but the overhead to having multiple locations is quite large. So we choose to condense into 2 main locations with virtual opportunities as well. And we have 30 staff on any given day. It's a very female-dominated profession, so it depends on who's pregnant, who's on maternity leave, and who comes back. Sure. Because we're all female. And it was a lot of people, but we also had a lot of people then who could do little pieces to make this team work, right? And everybody really wanted to be safe. And technology made that the equalizer. And what we found is having appropriate technology use opened our worlds. Some of our kids had better outcomes because we'd never seen them in the home environment. Because going to a home to see you in real time is not feasible, especially with the distance we cover, not just in Northern Virginia. We're in that little triumvirate of Maryland, D.C., Washington, D.C., Northern Virginia. And so some of our families come, a far distance for an urban area to get the quality care they're looking for. But it's not realistic for me to go from this suburb to see someone at home. But now I could see them back to back, and I could see them in real-time conditions. And I could see the equipment you were using, and I could see the stressors or whatnot. And it's become part of our plan of care that for many kids, we try and do at least one virtual episode every 6 months so we can check in on those things. We typically time it when someone's ill. So someone already has COVID, so they're not allowed to come in. They're a little under the weather, but just enough that they don't want to do much, but they could be at home and be on a screen. And so every 6 months, we'll try and use those opportunities. Instead of disrupting your plan of care, we'll see you virtually and check in on those things. That was one of the things that really helped. There was other technologies that helped, but those were more they're not your technologies. Like there was this great, I don't know how you would even call it, nano chemical that came out that they were using at the airports and in medical facilities, that if you sprayed it, it had this automatic cleaning action. And we had access to that in our area. So we paid a lot of money for it, but we felt really good about the cleanliness we could offer when we did open back up as we started to layer that in. Yeah. Those were probably the 2 big tech things.
I like it. And technology comes in lots of forms, right? We don't do nanotechnology, chemical incited cleaning agents, but that's obviously a very effective thing for a time and place. The area that we do see a lot of folks talk about, especially in the telehealth space, are what do we do about things like ambient recordings? So part of the ambient recording space or the transcriptions that happens a lot of times in practices, which is very growing. There's lots of organizations who are doing this. They're utilizing those technologies to be able to do things like real-time chat updates, questions, pings, alerts on how the conversation's going. So we have one practice that, as an example, has this technology in their space where as they're working through certain scenarios, they'll have little chimes that might pop up. Hey, be sure to ask about this, or this patient has dealt with this kind of diagnosis in the past. Make sure you look for contraindications around this kind of medication or this type of therapy. And it's really kind of an effective mechanism to be able to manage for those that are willing to kind of split their time and use technology in a way that is pretty uncommon, frankly, still, I think, in the practice. It's been effective. Then there are others that are just quite boring. There are things like I do manual forms. And so every time I fill out this form, I've got to get it into my EHR, and I need to be able to make sure that my patients have the ability to speak to somebody who is not at the front desk, but I've got to cancel, and it'll help them reschedule without actually using front desk time. So sort of AI receptionist work. And that kind of material is something that as practices start to adopt that kind of technology, we're finding that some of those practices are doing things like this. Somebody comes out of an appointment. By the time they come out, the notes from that appointment have already hit the front desk individual, and they're writing thank you notes for the patient who's coming back to the front desk to check out. They're saying that they're more aware of what's happening. We had one clinic that, in fact, oftentimes you'll have the physician or the A&P, maybe somebody sitting in the clinic doing the session itself. They'll leave. They'll use ambient technology to produce a series of notes. And when that next person comes in to say, here's your, I'll say, discharge paperwork, what pharmacy do you need to go to pick up your medications, those kinds of things. They're walking in with a knowledge of how the session went, sentiment, tonality, that kind of work, that when they walk in, they now know, is the person going to be in a decent mood? Did they just get bad news? Are they dealing with a certain kind of struggle? Is there somebody else in the clinic with them that might either be outside or in the room themselves, where they need to try and manage that relationship a little bit, or the words that have to be said? Do we need to change our tone about how we approach the discharge wording? Are they happy? Are they not? Like basic stuff that, as you learn how to engage the patients in a different way, that changes their ability to follow up their willingness to go to Walgreens or their willingness to go to Publix, wherever you might want to go, or ask them to go, changes by way of how they're feeling when they walk out of your practice a lot of times. So the data is pretty clear about that impact and how it is that you can educate staff to interact with your patients in a different way. So it's pretty cool stuff for sure.
I wish some of those tools were, unfortunately, I love what you describe, and I think that would work well for my best friend who works in a medical practice, she's a physician in a medical practice that very much functions on that model of mid-level providers, and there's someone who checks you in and there's someone who does this and takes your vitals. So the challenge that we find in our practice and practices just like ours, we're kind of these unicorns among the medical system. We hear it all the time from the EHR providers and some of the technology people, is that it's almost like a psychologist's office. So if you envision going to see a psychologist, it's just them typically. There's not usually a front desk person, or even if there's multiple providers, it's, they manage a lot of that on their own, because you would go once a week for a while. There's not a lot of new people on the daily, and there's a routine element to it. And they come pick you up and they check you out. And then at some point there's some sort of billing process and you continue. But the first time you need them, you just call them, and someone somewhere offsite, you don't walk in and ever talk to somebody. And that's a lot of developmental pediatrics, because we see kids with ongoing special needs. And so typically we need to see you every week or every other week or some sort of burst like that for a long amount of time. We have a lot of occupational therapists, and we specialize in children struggling with autism-related challenges, sensory processing disorders, and those kids can need therapy for at least a year at a time, to address a certain level of challenges that they're going through. So it's every Tuesday at 4. We don't need a front desk person for that. We do need a rear desk person for the new people calling, and we need a billing department for the billing, because we take insurance, which is not typical for private clinics in our area. And, a lot of those logistics, we need scheduling assistance, but we don't need, at the end of every session, we're walking out to say back to the parent, if they weren't inside, we're giving kind of a quick report. And so that type of tool is not what we need, but what we need is something that helps with the child who can't stand still when we have to update mom on the plan. I had a day of this yesterday, back to back. I run our bowel and bladder program. Many of the children who need my bowel and bladder support also have some sensory processing challenges. Some of them may have autism. Some don't, it can be whatever. But a lot of the kids come in, and part of the reason they're having challenges is a dysregulated sensory system or emotional regular system. And so by the end of a session where they've had to do some hard things, and then they got to play a little as a counter agent while we did some mapping out and planning, it's time to go. And mom has questions, and we're trying to do the schedule and check the thing and do these questions, and the kid's still bouncing off the walls or doesn't want to go and wants to bounce a basketball, and nobody can process. Or even in the morning, my first little girl, this girl that I really love, didn't want to leave because she was sad. She had such a positive experience. She's like, I want to stay here all day. I'm not leaving. But she's crying, right? And so the logistics are, I'd play with her all day and do therapy for 8 hours if I could. But I also need the room for the next child, and I need them to leave because I need to clean. And there's acute illness everywhere, so I need to clean. And now I'm at 1 minute in between patients. I haven't finished my note, because you just can't finish a note with a kid in the room. We're still double checking schedules because it's holiday season, so we're helping out with that. And now I'm behind the 8 ball. What I need is a therapy dog who can talk to the child and confirm schedules at the same time. I need an AI-looking therapy dog who will entertain the child, so mom and I can have a conversation and we can have a peaceful transition, because it doesn't help anyone in our waiting area to see someone being carried out and screaming either, right? We want to keep everybody on an even keel. That's the tool. Can you help me, Travis? Can we start doing AI-assisted therapy animals? So, they don't poop. They don't need to eat.
I'm not aware of that, Amy.
Okay, let's do it.
Here's what I would say. There's a couple things in there that you had mentioned that is pretty familiar. So I mentioned the ambient transcription. That is something that within KickstandAI we have experience with managing not only the ambient piece of this, but also the notes that I had mentioned that automatically drop into EHR, the summaries that are available, plus actions to take post-visit. So that space, which can be adjusted based on tone and kind of what it is that you're trying to accomplish around templates and scripts and those kinds of things, you can adjust them so that that period of time that you have gets a little bit wider, because of course now you have a bit more time and you don't have to go back to those notes at the end of the day and try to remember all the details. It's already there. You probably already have a summary. You might even have discharge planning or next action steps that tie potentially directly to your care plan. The other piece of it, and this is it kind of makes me laugh when you mentioned this sort of AI, service pet kind of a concept. There are the space of companions is a rather large space. It's growing frequently. And I will tell you that we did sit down and have a quick conversation on how it is that you could use a pad that has cartoon character avatars that can interact with a child at the appropriate level, age level, or developmental level, and be able to I'll say, engage the child, maybe not entertain, but engage a child in different kinds of ways. And obviously for this particular practice, it was tied to a parent-child interaction. It wasn't necessarily just entertain and kind of engage them and keep them doing something else while you guys settle something. So there was a very specific purpose. It was being developed for that purpose. But just the idea of the companion, it's not a far stretch from, furry robotics and the engagement of a companion bot that a child could conceivably be talking to a fuzzy little robot that's talking back to them. It doesn't sound like the Jetsons anymore. Like these days, that's quite a bit more like reality. So that I would say is a little bit farther stretch, but it's not too far. And if we get to a good opportunity, maybe you and I can just chat some more, because I'd love to sort of pick your brain. Just as someone who's so enmeshed in this kind of work, you probably have some other great ideas, but those are the kinds of things.
And I'd love to hear more about that interactive pad, because you mentioned it and already my head's spiraling, and that could be a step one alone that I could see where our practice could use. Different programming, but in the same context. But so yes, we'll definitely talk more, but it's reassuring to hear that it's happening somewhere. I think,
it is.
Looping back to some of our global challenges is because since that's the theme of a lot of what we prepared for today, is the isolation between disciplines, if that makes sense. So, I'm trained as a physical therapist with a specialty in pediatrics, and my, boss, my owner, is an occupational therapy in traditional in pediatrics. She happens to be a phenomenal entrepreneur because she comes from a family who's owned a lot of small businesses and had really good instincts, and now has the financial wherewithal that we can hire good business consultants to help us, and they are phenomenal. But none of us are business trained. Everybody we work with is healthcare trained, and we have a really specific demographic. I mean, most developmental pediatric therapy practices are almost exclusively women, and half their staff is going to be new graduates, like all in their pre-marriage, pre-childbearing years. And then there's a bunch of us that stay on, we get through pregnancy and raising kids and not working full time, and then we're back to full time. And then attrition is really a hard challenge lately in general, but also then attrition of who we know. I don't interact with anybody on a given basis who isn't in medicine, who isn't literally female, and unless they have people in their families who also do cool things like you might do. Like I don't know you except for this, but you could be my brother-in-law and then I'd know you. But unless we have those people as part of our general zeitgeist, and most of us stay friends with our people from graduate school. So all of us are friends with our friends who are either in the medical program or in the pharmacy program. So we know all healthcare people. It's really hard to access this, right? It's really hard to know someone. It's hard to even know which podcast to listen to get access to this. And that's where I love that you guys all found me somehow, and that we could have a conversation like this, because we don't know where to reach out to initiate the conversation.
Mm-hmm. Yeah, it's a world of noise, and that is sort of one of those issues with just the social space. But it also creates these opportunities where you can connect with folks that you never expected. We were chatting a little bit earlier about connecting with folks that just you would never expect to respond to your email or your messages, or to just be part of their circle. And you kind of get into these interesting conversations with people you don't expect to, and you realize that every single time you have that conversation, you learn something new. Your world is kind of expanded a bit. You start thinking about things in different ways, and that's this kind of conversation, right? It's our ability to really kind of amplify your voice in a way that makes a lot of sense for us to connect with leaders who are moving and shaking in these kinds of spaces, to say, what is it that you guys would find particularly useful? What's the real practical problem? That's why we're created. That's why we're here, right? KickstandAI is based on the premise of solving very just practical things. There are organizations that solve very large problems, right? And that's the folks that are throwing hundreds of millions of dollars at agentic AI and technologies that create GPT kind of content. The reality for us is we walk in, we hear how things are going, and we solve a problem at a time. And we just keep doing that over and over and over again. And it takes a little bit longer, but it's effective because it hits the valuable things for the folks that we're talking to. So that's why we're in this space. But on the topic of how it is that organizations like yourself, and you kind of reference yourself as a unicorn organization, it certainly can feel like that for sure. And as you think about I'll say maybe despite the fantastic entrepreneurial spirit, skills, intuition, gut feel of how your guys' founder, how Sarah's managing the world, how do you see things like this sort of trickle, the drips of sort of fiscal responsibility that just kind of drifts away, and you're like, man, that's just like soaking up dollars for some reason. We just can't solve whatever this is, or it's a waste of time and we just can't figure out how to nip that in the bud. How do you see in your unicorn organization, where does that land for you guys, and how it might be different than others?
It's a big old bullseye. And I don't know that's exactly maybe different than others, but for someone like us, 30 employees, 2 locations, we're not small, but we're not big. And so it's almost a mom and pop organization, right? Anything we can do ourselves, we do. And so we're always robbing Peter to pay Paul, from something, right? Because I'm either doing this project or I'm seeing patients or this or whatever we do with the staff. And there's finite amount of money for any of this. And so I think the biggest bullseye for us is, what can we manage ourselves at not an opportunity cost or opportunity lost for the real reason we're there? I mean, the real reason I'm there is to help kids, right? The real reason I am is to guide them with this very specialized knowledge that not a ton of people have. So that's what I should be doing most of all. But I also have to help manage our social media. I have to develop tools with whatever. And so like handouts and slideshows and slide decks and things like that. And in the meantime, we still have to replace equipment. We have hundreds and hundreds of thousands of dollars of very specialized equipment that hook to hooks in the ceiling, that are specialized swings or mobility equipment, and things you need to use with a treadmill for safety. And so those are the non-negotiables. You can't run clinics without this kind of equipment, and we don't have hospital overhead. So what do we do? And then we choose to take insurance as something we feel is important to families, which is, again, not common, which means we do write off a lot more than the non-insurance using clinic. And we pay people to help us with it, right? So we're trying to use these are the things we're like, is it ethical? Is it this? Is it that? Well, the biggest pain point is how to prioritize what we do need to pay for and understanding that. For instance, we have a website. There are certain things that are good to do in a website. Unlike other businesses, we don't need it for as much as other people do. We don't sell products. We have a lot of information, but we can give handouts and sessions. Do the parents go home and log on for handouts? Like, what can we do? But then I started running community classes to teach tummy time. And what would be easier right now is to have a scheduling system on my website that we just post a schedule and. And when we went to add it to our website, it was going to cost $10,000. And the community class is for $25 a family to learn how to do tummy time and developmental skills. I don't know how many I'd have to have for $10,000, but it wasn't it. So right now I manage it with email. We use Google Workspace, which is very helpful for many things. And I use as many tools in Google to track the names of people we've seen in classes and hand email them and hand register them. And we take checks and cash. And it's working so far. But I can only imagine the outreach of this. But we were like, well, where do we rob Peter to pay Paul? Do we need a whole new website? Because everybody in the gig economy has their product. So when we've looked, we're like, we just need someone to update our website for these specific things, whatever. And everyone's like, well, you should eat, but don't lose our SEO, because we paid a lot of money for a year to get some good SEO. Yeah. So then it was like, well, we don't love your website for self-use, so we'll happily make you a new one for $10,000 and layer this in and layer in your SEO. Or this. And that's where I think a lot of places like us get stuck. And those are just my tangent examples. But some of the technology is probably affordable if I knew where it was and we had a connection. But we still have to use the EHR that we're using. And our EHR has to be linked with billing software. And this is the billing software and the EHR that worked best for our clinicians and our biller. Okay. Right? And so now we've got a really small pool. We use Practice Perfect, okay. EMR. It's through, it's a Canadian company. Yeah. And it's not perfect, but it works well. They just launched their AI, their Scribe AI. It's in development. We're beta testing it. So that's great. Every time we add a feature like that, it costs more money, right? And for tools that don't make us more money. And maybe that's the theme is a lot of the tools we need don't make us any more money. And in fact, people are constantly trying to pay us less money unless we want to bill that to the family who's already struggling. And so it's that kind of world where we're like, the best that I can do is the better I am at my job, I can get people through faster and potentially let their individual cost per unit or, cost per patient be less. But it doesn't necessarily use less energy. It doesn't shorten how much air conditioning I'm using. I'm not buying less groceries. I'm just helping more people and I'm doing it faster. Does that make sense?
It does. And it's actually, you mentioned the unicorn. I'm going to toss this one at you as well. Most of the data actually says that rather than folks seeing more patients, what they're seeing is that things like turnover staff burnout, attrition, those kinds of things are decreasing with technologies. So it isn't impacting the patient throughput much different than it had been in the past, but physicians, providers are happier, probably providing better quality care, probably looking after their patients more frequently, probably reading the notes more thoroughly before they go into session. They're probably spending more time talking to the families. They're interacting in different kinds of ways, which in the span of the world of healthcare, that's exactly what they should be doing, right? So if there's a point of where you're seeing the dollars to be gained, yes, there's always topside revenue if you could see more patients potentially. There's also the ability to have happier patients, them essentially act as referrals because they're so happy, and then thus seeing an organic growth to your business as opposed to trying to just see more and more and more and more and more. So the data is...
I should rephrase that just to make sure. We have all of that already. We are maximized for capacity. So we don't need more capacity, and we can't do it. So for like our day-to-day capacity. So our goal would be to be able to get more effective outcomes quicker with less staff, burnout or just, fatigue, so that we could get through more people in the community who need it. But we are at a point where we want to be more efficient, to access our better outcomes quicker, to give more opportunities at the community level. Like this tummy time class is to prevent kids from needing therapy in the first place. If I can offer a $25 class, and that's going to help, reduce 30% of the people who might need intervention just because they can't do tummy time, we'd like that. The tools to link all of that together are hard. I think what we're finding in our unicorn specialties, the specialty areas, are wait lists, lack of access to really qualified people who really have had time to engage in their specialties, like a bowel and bladder specialty is very rare. And we feel the pressure of knowing how many more people want to come on the daily than we can provide. So any of the technology that helps us get there, our revenue would be fine. We want to manage, we don't want to spend more. We want to still be able to pay our providers well and support everyone and have good health insurance and things like that. What we really are, most of our talks are about, how do we make sure we're not making people wait too long for services? How can technology help us with that or prevent the need in the first place?
Fair. Well, I'll have to bring us to a bit of a close here. It's been a fantastic conversation, Amy. I absolutely appreciate your time. Any final words on your unicorn Good Beginnings pediatric therapy practice? Love to hear it in 30 seconds. What do you got?
All right. Well, always check out our website, gbtherapy.org, because we have tons of free resources on there for people, as some specialty programs that may not exist in your area. And we're always happy to talk to you about how you would start one in your area. I think the rest of my plug would be always go see a specialist and see if your questions can get answered. Even if it feels like it's costing a little more, get a specialist who's really a specialist in your area and take the time for at least the one appointment to get your questions answered, because none of us are so slow that we would bring you in just for fodder. Like we're going to prioritize how to get you the help we need. And if you've got a very rare thing or a specialty that's not commonly found, go to the people who really know what you're doing, because then you'll get better outcomes quicker.
Awesome. Well, thank you, Amy. Two decades of experience with Good Beginnings. I know I missed out the first
Crazy,
part,
right?
But fantastic. I appreciate all your time.
Thank you.
I am sort of aside here from our podcast discussion. I'm going to reach out to you. I'm going to send you a little bit of some just quick clips on how things are going here with the podcast. We'll keep adjusting some material, and I'll get on your schedule. Does early next week work for you as far as taking a look at some clips and then come back around to have some additional conversations about the remaining pieces and maybe some other operations?
As long as it's on a Monday. So I can't do anything when I am in clinic. And so Mondays are my admin days. I have a bunch of meetings next Monday, but if we can overlap for 45 minutes, that sounds perfect.
Okay. That'll work. So is Tuesday better? Like is Tuesday, Wednesday?
Tuesday, Wednesday, and Friday are my clinic days. All patient care all day. So Thursday would also be okay.
Okay, Monday, Thursday.
Mm-hmm.
Gotcha. Okay. I'm going to reach out to you. I'll send you a quick invite. I'll send you a few links here in the next 24 hours, and we'll be all good to go.
Sounds great. Thanks for having me today, Travis. I really enjoyed this.
Thanks, Amy. Wish you the best.
Okay. You too. Bye-bye.